Hello. Good afternoon to everyone. A very warm welcome to all for spending your precious lunch hour with us to join us for this second webinar organized by ACE MOH, focusing specifically on several aspects of asthma patient education. Just a brief introduction about myself. I'm Ning, a consultant working at Changi General Hospital. I'm the director in charge of the pulmonary function lab over here and have a special interest in airway diseases, especially asthma, as well as lung function. So a few housekeeping matters before we proceed. You may have noticed that the mic, video, and chat functions have been automatically disabled for all attendees, but rest assured, all those questions that have been received at the registration, we will try to address them during our presentation itself, or they will be discussed live during our Q&A section at the end if time permits. During the entire course of the talk, please feel free to send in your questions via the Zoom Q&A function. We will try our best to answer it either verbally or through the Zoom Q&A function, although we may not be able to get to all questions. Questions that are relating to our topic at hand today on asthma patient education will be prioritized. So next slide. So today, joining me on the panel, I have three esteemed colleagues from nursing and pharmacy. They are Sister Lathy, Mr. Kheng Yong, as well as Miss Joy Chong. Sister Lathy is a senior nurse clinician at Tock who specializes in respiratory nursing, and Kheng Yong is a senior pharmacist at SGH who leads the asthma and allergy clinical services, while Joy is a principal clinical pharmacist at Watson's personal care stores. Next slide. So the aim of the webinar today is to improve asthma care and outcomes through patient education for asthma patients from medical, nursing, and pharmacy perspectives. The reason is because all three professions have an important role to play in this. So aspects that we'll cover include things like asthma symptom assessment, medication, as well as adherence counseling, as well as the written asthma action plan. So we'll aim to keep the content as easy to remember and practical as possible. So starting with some background information, asthma is one of the commonest chronic respiratory conditions in Singapore. However, asthma outcomes in Singapore, be that exacerbation or missed days from work or school, still remain suboptimal in Singapore despite having very effective treatment being available. So despite having wide availability of ICS, the use of ICS in Singapore actually is one of the lowest in 8 countries in the Asia-Pacific region, with only 1 in 4 patients aged 12 and above using a preventer in the past month before their exacerbation. And this problem is actually multifactorial. Amongst others would be things like adherence to treatment, inhaler technique. This is also further compounded by a mismatch between the patient's understanding of what constitutes good asthma control and the actual reality of their outcomes. So in a survey by David Price et al. From surveying asthma patients from 8 Asia-Pacific countries, 73% of them who had one cause of PrEP in the past month for worsening asthma control or exacerbation actually felt that, as compared to 90% who actually felt that their asthma was under control. Next slide. So this graph actually shows very clearly that our asthma hospital admission rate locally is actually higher than a lot of other countries in the OECD region. Next slide. So as we would all know, the hallmark of good asthma management is the prevention of symptoms as well as exacerbation, and also prevention of long-term adverse outcomes such as deterioration in lung function. So what has significantly changed in the recent 2 years for asthma treatment guidelines is that the role of ICS as a preventer inhaler treatment has been extended to even the lowest treatment steps. That means even for patients with infrequent or minor asthma symptoms. This means that SABA alone treatment for asthma is no longer recommended. And in fact, this, in my opinion, is a right shift towards the right direction. It emphasizes the role of ICS being the most effective preventer treatment, which targets the underlying disease process of airway inflammation in asthma. Next slide. So the move to include ICS even in the lowest treatment step is actually supported by latest evidence showing benefits over using SABA alone. And they include halving the risk of exacerbation, improvement in asthma symptoms, objective lowering of airway inflammation as assessed by FeNO, as well as improvement in the PEF readings from baseline. So in fact, epidemiological studies also show that daily low dose ICS actually reduces mortality risk when compared to no ICS alone. Next slide. So with this background in mind, our ACE actually published Singapore's current clinical guidance on asthma in October last year with the latest evidence to recommend ICS across all treatment steps. So yeah, you can access the QR code for further details. Next step, next slide. So, and in fact, recognizing the importance of working with our patients to educate them and to optimize asthma outcomes, the ACG actually included a recommendation on patient education, which brings us to today's topic. So all healthcare professionals have an important role to play in asthma education. So the principles of asthma education that will be shared in this webinar will be broadly relevant across patient groups for clinicians to try to personalize to their own individual patients. So this is a local study by actually Sister Lathy and colleagues who showed that a well-structured inpatient asthma education program targeting inpatients before their discharge, coupled with reinforcement by doctors and asthma nurses in the outpatient clinic, is sufficient in reducing the outcome, achieving outcome of effective self-care management. And in fact, it has been shown to reduce ED visits as well as hospital admissions. So this enforces the importance of having an asthma education program to equip asthma patients with self-management. Next slide. So pharmacists are also in an excellent position to educate our patients on inhaler technique, as they are usually the last healthcare professionals seen by patients before an inhaled medication is used. So international guidelines actually recommend that pharmacists should form part of a team approach to educate patients on inhaler use. Marchetti and Helen Riddell and colleagues actually studied the outcomes of a simple educational intervention to teach DPI technique by community pharmacists, and it only takes 2.5 minutes to do this educational intervention, and it was targeting the inhaler technique. It was found to be feasible and in fact resulted in significantly better inhaler technique, improved asthma-related quality of life, and perceived control of the patient's asthma. However, of note, during the last 3 months when there was no further monthly retraining of the asthma inhaler technique, the inhaler technique actually declined. So this also goes to show that rechecking and re-education of patients on their inhaler technique needs to be a regular and ongoing process. So Extel and colleagues also showed that a 2-minute pharmacist counseling session, in fact, was more effective than other interventions, such as just watching an inhaler video, reading the MDI insert, and so on. So this reinforces the pivotal role that pharmacists play in reducing the implications of improper inhaler use. Next slide. So a written asthma action plan is an individualized written plan written by a healthcare professional for a patient with asthma. Basically, it educates as well as guides the patient on self-management of their symptoms were it to worsen in a traffic light kind of configuration. So green zone generally means adequate control and the patients are to be on their baseline medication, whereas yellow zone usually depicts a loss of control, and there will be corresponding instructions for therapeutic intensification, whereas the red zone will indicate severe symptoms and that it should prompt the patient to seek immediate medical assistance. So a Cochrane review done by Gibson et al. Of 36 RCTs regarding the use of WAAP in conjunction with education and regular clinical review actually shows that it significantly reduces healthcare utilization, reduces absenteeism, asthma symptoms, and also improves quality of life. And it has also been associated with a 70% reduction in mortality. So with this strong evidence, international asthma guidelines actually do recommend that all patients receive a written asthma action plan. However, despite these data, in general, WAP provision as well as use remains poor. This is partly due to prescribers' inability to complete the yellow zone instructions on how to intensify the treatment. Other barriers include lack of time or experience or confidence in carrying out the AAP recommendation. Of note, international guidelines, although they provide evidence-based recommendation on how to intensify, they do not actually operationalize for us how the dose intensification should be carried out. So this makes practical implementation of WAP complex. So with this background in mind, I'm going to share some overarching key principles on how to broadly apply WAP across patient groups for you to personalize for your own patient. Okay, so with regards to treatment escalation in the yellow zone, in general, the first principle is we should aim to quadruple our patient's maintenance ICS if possible. And typically this is for a duration of 7 to 14 days. However, take note that before you decide whether or not your ICS can be quadrupled, a few key considerations that you need to take note would be, is your patient on at baseline on a combination preventer reliever regime at baseline? What would be the maximum daily dose of ICS and or LABA if they're on a combination inhaler with respect to the patient's age? So, and all this information, typically you can get it from the individual package inserts of the medication if you need to refer. However, in the table on the right, I've just included some examples on the maximum doses for some of the commonly used LABA and ICS. And also take note that in certain countries, the country itself also has regulatory limit on what the total daily dose would be. But in Singapore, usually we follow according to the package insert. So in general, if your baseline ICS dose does not permit a fourfold increase in the dose without exceeding the regulatory limit, actually there have been studies specifically for certain types of ICS that it would be actually safe and efficacious to at least increase it to the maximum daily dose, okay? Even if this is not 4 times. This applies to high dose inhaled fluticasone propionate, cyclosonide, or budesonide. Yeah, and studies have actually shown for these 3 ICS that just by increasing it to the maximum total daily dose, it is as efficacious as giving a course of oral corticosteroids. However, this also means that for other medications, such data are lacking. So 2 options are possible. It's either you consider temporarily increasing beyond the regulatory limit to reach 4-fold, or you consider going straight to a short course of OCS. For example, with regards to going straight to a short course of OCS, it might be relevant, for example, for certain medications such as Relva, where the LABA component, which is already at 25 and is a maximum dose possible, it will not be safe to increase it beyond that. So that's why for such patients, typically they will need an immediate step up to a course of OCS. However, the reason why there is a benefit in temporarily increasing the ICS to 4-fold, even if it's beyond the regulatory limit, is because there are 2 different schools of thought. Firstly, generally, the maximum dose quoted for the maximum daily dose is usually based on chronic use and not based on short-term use. So, and for certain medications such as cyclosonide, in fact, there have been some studies saying that it is still safe even if you use it beyond a regulatory limit. And in fact, since the goal of AAP is to actually prevent the patient from requiring a course of oral corticosteroid, which by itself would have attendant side effects and risks as well, perhaps even higher than ICS alone, it is still a goal worth achieving. However, of course, bearing in mind, we do know that patients sometimes may not be comfortable in consuming medications that exceed the product insert. Pharmacists also may object to dispensing it beyond the maximum regulatory dose. Clinicians also may not be comfortable writing prescriptions that exceed the regulatory dose, and there may not be safety data available for shorter term, higher dose usage beyond the regulatory dose. So at the end of the day, it may not be applicable for your patient. So, but all in all, in order to choose between the option of temporarily increasing beyond the maximum dose versus going straight to a short course of OCS, I think it needs to be a conversation that and a discussion with your patient, and to see which one is more suitable and which one everyone is most comfortable with. So basically, just to recap again, in summary, is firstly to try to quadruple if possible. If not possible to quadruple, at least consider increasing it to the maximum daily dose, especially for fluticasone propionate, budesonide, or sikasonide. Bearing in mind not to exceed the maximum dose of LABA, especially if the patient is on a combination LABA ICS inhaler. For others, you can consider two options. One is either going straight to a course of OCS, or still, after discussing with the patient, exceeding the maximum ICS dose. So with regards to OCS, in general, guidelines with regards to AAP have been consistent in that if increasing the ICS dose itself did not work in terms of helping the patient improve their symptom and the patient continues to clinically deteriorate, a short course of OCS can be considered as a second line in the yellow zone. In fact, some international guidelines actually suggest going straight to a course of OCS if the patients have certain high-risk features. For example, the BTS sign guidelines suggest that if the patients are already on moderate high dose, more than 400 micrograms BDP, or if their FEV1 is less than 60% predicted, or they have had history of severe asthma exacerbation, such as stated in GINA guideline, you can consider going straight to OCS course. Typically for OCS in literature is 30 to 50 milligrams per day for 5 to 7 days, but typically our local approach is for 30 milligrams per day for 5 days. Of course, having two steps within the yellow zone itself may cause additional confusion for your patient. So with regards to whether or not you should give a second instruction for a standby OCS, you could operationalize it in a few ways, depending on the suitability of your patient. So one is either to get your patient, provide a criteria for a patient to call you as the primary physician for an OCS prescription if needed. And to provide either that, or you can still provide a standing instruction for conditional course of OCS if they have excellent self-management skills. So yeah, with regards to reliever use PRN, it would depend on whether or not they are on salbutamol only or ICS formoterol as a rescue or MUT. Okay, so in general, for salbutamol only, the maximum dose is 8 puffs per day, 800 micrograms. For children less than 12, it means 1 to 2 puffs per day. So if they are on MUT with ICS formoterol or PRN, there's two approaches. So if they are on PRN, you can either just encourage them to take the increased usage of ICS formoterol PRN depending on their symptoms, up to a maximum dose of 12 inhalations per day, or you can alternatively switch them to a daily low dose for 7 to 14 days with the PRN usage as needed. Whereas if they are already on regular ICS formoterol plus PRN as SMART, you can just continue a daily ICS formoterol at the usual dose and to use it PRN up to the maximum possible if needed. So just take note not to exceed the maximum dose of LABA. Yeah, so in general, also remind your patient not to wait until their symptoms really worsen before going to the red zone. And in general, for kids less than 12 years old, the threshold to use steroids will be higher. So typically for this group of patients, we would just advise them to continue their prevented inhaler as per usual and increase the reliever use PRN to maximum dose and advise them to seek medical attention if not better, or go back to their primary physician earlier. Next slide. Okay, so in general, these are just some additional rationale when prescribing in the yellow zone to try to always maintain the prevented inhaler for the yellow zone so that the patient does not forget to not take it after they are done with the yellow zone. Also, for example, if the patient is on OM usual dosing or BD usual dosing, try to keep to the baseline frequency and instead add on inhalations instead of changing it from OM to BD, because the patient may get confused once they're out of the yellow zone. And try not to add on a new inhaler. This is because it adds cost to the patient and becomes quite complex in terms of filling new prescription. And if you really have to add on a new inhaler device for the yellow zone, try to use the same device as the baseline preventer. And when stepping up, aim to keep the inhalations to less than 4 per use. Because one puff alone takes 1 minute, so beyond 4 minutes per administration, it becomes quite impractical for the patient to use. Next slide. So in general, for the red zone, it will be to seek medical attention immediately and to encourage the patient to use PRN. So just take note that the patient can repeat the usage every 1 to 3 minutes. And whatever that is stated here is based on what we could find in literature in terms of the highest recommended dosing. But bearing in mind, usually in the red zone, the patients are quite unwell. So if there is a need to, the patient can continue to take beyond the maximum recommended dose if needed. And if they already have a standby OCS, they can take the first dose of OCS as well. Next slide. So overall, self-management with asthma patient education is important, and it should preferably be given by all providers and at all points of asthma care. So, and in general, it has been shown that patients who can manage their symptoms are able to have better outcomes, and all as healthcare professionals can be successful educators. So with this, I hand over the baton to Sister Lathy to share her invaluable experience and perspectives from nursing point of view. Sister Lathy, please.
So let's start with the important tips when providing asthma patient education. The important tip, the first one is the order of information. To provide with the most important to the least important. I will explain about this in my later slides. Don't be caught up with what information you want to give to the patient, but to understand the patient thinking, feeling, and wanting. Avoid medical jargons. Speak slowly and use simple words. Thirdly, illustrative antidotes. The instructions which we want to give, we can give it through drawings, pictures, flip chart. It all depends on patient's age and literacy and educational needs of patient. Teach back method. Confirm understanding by asking questions that patient is able to repeat. To give them an opportunity to share their information and express their opinion. Non-verbal communication. Pay attention to non-verbal communication, like watching time, using handphone. So be clear and concise. Don't lose your patient. Encourage questions. Ask patient, make patient feel comfortable about asking questions. Be able to empathize with patient and caregiver. These are the tips which we want to remember when we give patient education. Next slide, please. So to identify patients' asthma educational needs, we want to look at three parts of this. Asthma control, treatment issues. Patients can be referred to us as new cases or probable asthma, or they have change of treatment. So we want to give them information on knowledge and skill, and also they might come in just for addressing questions and concerns. Next slide, please. So let's look at how we will address educational needs according to the gaps of asthma control. So to assess asthma control, there are a few tools which we can use. The tools that we can use are ACTs, asthma control test, asthma control scores. ACE have some recommendation on their side. So these tools are used to get an objective score to understand the asthma control. So ACTs, usually when we use ACT is to assess day and night symptoms, use of relievers, and whether the patient is able to do activity, normal activity or not. And also to look out for telltale signs like peak flow reduction if the patient is using peak flow at home. So assess comorbidities. Assess comorbidity. If the patient is heavy, then we want to do weight, trends of weight, see whether there is edema, allergic rhinitis, gastric reflux symptoms, or disturbed night sleep. Follow up on flares and contributing factor. So we want to look at unplanned GP visits or ED visits. Use of WAP, whether the patient is increasing the dose of reliever or preventer or using prednisolone. Next slide, please. So the next one is to personalize our education message according to treatment-related issue. So on assessing medication adherence, I will speak on it later. On assessing inhaler technique, we will check in each visit, we will check inhaler technique to see whether it is a contributing factor for poor asthma control. Mr. Ong, our pharmacist, will address it later. Assess adherence to other intervention like smoking. If the patient is a smoker, making change in behavior is not a simple process. Take first visit as an opportunity to understand patient and his plans on changing. For further reading, if you want to know about changes in behavior, there is the 5 stages of behavioral change. So the next one is to review changes in treatment. What was the patient's treatment prior to his visit? What is the current change? What is the reason for the change? All this we can explain to the patient so the patient understand the treatments that were changed. Discuss reasons for change and how it will work for the patient. Then to review and update WA written asthma action plan. So when we do changes, we want to update asthma action plan according to the changes that were done for the treatment. Next slide, please. So the 7th recommendation of this guideline is the need to educate all patient and caregiver on how to self-manage asthma. So it also depends on the ability and willingness of the part of patient and caregiver to take responsibility, whether they are ready to learn and to change. Social and psychological support is also necessary to assist with positive behavior change. Thus, to make asthma education meaningful, it should be equipped with a partnership with healthcare provider, caregiver, also adding on knowledge and skill. Then it will lead to good asthma and outcome and be meaningful to the patient. Next slide, please. Communicate key components of asthma education. So to assist current understanding and underlying disease process, what is patient's understanding of his disease process? Instead of just telling the patient what asthma is, understand what the patient wants to know about asthma, and also understand what the patient understands about chronic disease. It is very important because it's a lifelong disease, so they will want to know, you want to know what they understand about chronic disease. When patient tells me he do not want to depend on medication for life or do not like to take medication, what do? I will acknowledge, at the same time, I will find ways to give that person a hope to hang on. So hope reduces feeling of helplessness, increase happiness, reduce stress, and improve our quality of life. The second part is encourage better self-care behavior. Help patients to avoid asthma triggers. As mentioned earlier, behavior change do not happen in one section. The first visit in their first visit, assess their triggers. Here, I will deal with the easy ones first, then go on to the difficult one. For example, if the patient has a pet, know the pet, I will try to know the pet more, even make an effort to know the pet's name, the sex, check out the photos of the pet, because it and who the pet belongs to. Slowly address this, because I want to build a relationship with the patient, so that the patient in my next visit will agree or take measures to prevent exposure to the pet. So same thing if on advising on smoking cessation, note down every effort that was made to reduce smoking. What are their plans? Like what the famous quotation, Mark Twain says, giving up smoking is the easiest in the world. I know, because I've done it 1,000 times before. So smoking cessation and trigger avoidance, it's difficult. So partnership with the patient to try to reduce the exposure of triggering factors. Ensure follow-up appointments are given. Long-term reviews are needed to improve asthma. What is the expected time frame the patient would want to come back for follow-up? Next slide, please. So how to identify poor medication adherence in asthma patient? Most patients who have chronic diseases, their compliance, their adherence to medication is low. Same thing for asthma, their adherence is approximately around 30 to 50%. So when the patient comes into my clinic, I will beforehand check on the filling of prescription, the dosage and frequency. Use empathetic questions to ask them. Like I will ask them how to identify the inhalers that they are using through a poster. Then ask the patient how often is he using it per week. Then proceed to how often are you using it for in a month. So I can also ask, do you remember to use the inhaler more often in the morning or in the evening? So all this indirect questioning, you can see whether the patient is compliant with the inhalers or not. So acknowledge incomplete adherence, open non-judgmental discussion. When the patient say, I don't have symptoms, I don't use my inhaler. So if he say that, I will not go and say they are wrong, but I will assess and see what is their control like. What do they mean by I got no symptoms? Are they still using the reliever inhaler or not? What is the asthma control test course objective measurement? How am I to tail down? Is he ready to tail down the ICS? So I will also tell them ICS cannot be stopped abruptly. It should be tailed down. So if he's not using, we'll see and see whether we can tail it down or not. Then also the third point is to check on medication use. So usually what we do is to check on prescription and the filling of prescription before the patient comes into our clinic. Next slide, please. So medication, addressing medication-related adherence, it can be due to regimen factor, difficulty using inhalers. Patients might have arthritis. So find alternative device that will make the activation of the inhaler much more easy. Multiple inhalers, like patient might be given PMDI, Turbohaler, and Respimat. So to learn 3 inhaler device, it might be difficult. So try to ensure that that we do not give more than 2 types of inhaler to the patient. Burdensome is regarding the frequency of dosage of inhalers. Unintentional is patient's misunderstanding of instruction on how much dose he is taking. Forgetfulness, rushing to work. when rushing to work, they forget. Absence of daily routine. It is not a daily practice. So we find their routine and try to add the medication according to their routine. Cost can be also a factor. So for intentional adherence is denial, anger about diagnosis. So if the patient is angry and denial, do not believe he has asthma, give alternatives, come to an agreement. Perception of the treatment is not necessary. They don't think they need treatment. Optimum knowledge, suboptimal knowledge of the use of reliever and preventer. They do not understand the difference between reliever and preventer. Also can be due to side effects. Stigmatism. Preventers are mainly used at home. So use morning and night at home privately. So if the stigmatism is a problem, then explore further why. Cultures and religious issue. Patients do not want to use inhaler because they are using traditional treatment. Cost can be a factor. So we have to address all these adherence problem to improve compliance. Next slide, please. Next slide. So communicate key components on asthma patient education. Teach how to recognize worsening asthma. So symptoms of worsening asthma are like frequency of night and daytime symptoms. If it's more than twice a week, whether their activities are restricted or not, whether when they are cleaning their house or walking to the bus stop, they become breathless. Signs of cold and allergy. Most of our asthma patients, the first triggering factor, the main common triggering factor is upper respiratory tract symptoms. So signs of worsening asthma is increased use of reliever. If the patient is using reliever more than twice a week, there is increased use. Then frequency of visit to the doctors and decrease in lung function. Providing written asthma action plan. Patients should have written asthma action plan according to health literacy level. ACE also have different types of written asthma action plan. Use written asthma action plan to prevent symptoms and flare up. Recognize worsening asthma, stepping up medication like preventer, reliever, and oral steroid, and when to seek medical attention. Next slide, please. So this is one of the asthma action plan. Like I've mentioned, asthma action plan are given according to the health literacy level, and when to provide WAP needs to be taken into consideration. Not every visit we give, maybe we can give further, because according to informations which we are providing for the patient, whether the patient is able to understand or not. So for the stage 1 green zone, when their asthma control is good, then we reinforce that they continue on daily preventer medicine. Stage 2 yellow, if there is caution or warning signs, then we will teach them how to respond to warning signs like increasing reliever, increasing preventer. You can either double or quadruple it to the maximum daily dose, and review response. After increasing, we review response. Stage 3 is worsening signs and symptoms. Despite increasing the preventer, adding on, if they still have, then we want to know whether is it a time to add on prednisolone tablet or not, and to contact doctors for early review. Stage 4 is danger zone. So to get doctors help, to see doctor immediately, do not wait, call for an ambulance. The first aid, we also teach first aid when we give asthma action plan. First aid is like using relievers, how many puffs of relievers till they reach the hospital. I think I come to my end of my presentation. My next presenter is the senior pharmacist, Mr. Ong. Mr. Ong.
Hi, Sister Lathy. Thank you for the introduction. So we're actually running a little bit short of time, so just to speed up in my section, but don't worry, because actually quite a fair bit of it is already available in the ACG guidance and its appendixes, so you can take a look at that. Now, my main role today is to emphasize the importance of use of ICS, as well as some tips on how to select an inhaler device. So as I mentioned many times, ICS is actually the mainstay for asthma. In fact, it is the single most effective treatment for asthma because it directly addresses airway inflammation. Okay, so in a previous meta-analysis that was done, it's shown that ICS can reduce exacerbations by as much as 55%. And this is more than any other of the asthma medications, including Montelukast, which only reduces it by about 41%. Okay, the bulk of the medications are actually delivered via the inhaler route. And this is because this route is able to produce higher local concentrations and therefore better effect. And at the same time, there's less risk of systemic side effects. Okay, as you can see from the diagram on the right, which is not even exhaustive, there's many devices available in the market. And sometimes it can be quite bewildering as to, so many different looks and appearances and how to use them. And the devices do differ in terms of how well they deliver the drugs, because there's differences in formulations, particle size, even the velocity of the aerosol cloud that's delivered by the MDIs. And of course, the most important one is still whether the patients are able to use the devices correctly. Next slide. So these are just some of the common ICS that are available in Singapore. So you can look it up on the ACG website. So the chart also comes with the suggested low, medium, and high dose ranges for each of the different ICS, as well as those recommendations for the different age groups. Okay, but do note that this is not a table of equipotence. This is mainly the based on the product recommendations by the product inserts. So a medium dose range for one device may not be exactly the same as the medium dose for another device. So whenever you switch from one to another, do make sure that you follow up with the patient more closely. Next slide. Okay, for ICS, generally the risk of side effects is very low, much lower than the OCS, especially if you are using low doses or even medium doses. However, some side effects are possible. So this includes candidiasis of the mouth and throat, also known as oral thrush, and some hoarseness of dysphonia. However, all of these can be prevented very easily by optimizing the patient's inhaler technique, using a spacer devices, or simply just rinsing their mouth and throat after using the inhalation. Next slide. Okay, if there is a need to step out from using ICS, most of the time we will prefer adding a LABA to even low dose ICS. Due to their synergistic effects, it achieves better outcomes at a lower dose of ICS than if ICS alone at a higher dose. So generally, nowadays we use fixed combination inhalers. This is preferred because it's more convenient, and having two medications in the same inhaler will increase adherence, and also ensures that the LABA is always accompanied by ICS. And in recent years, the guidelines have also started recommending using ICS formoterol as a reliever instead of SABA. And this is due to the rapid acting nature of formoterol. Next slide. So how do we choose a device? And it's very important that we consider whether the patient can use it correctly. So do consider patient preferences as well as their ability to use the device, as this will affect their adherence to treatment and therefore the effectiveness of the treatment. So problems with incorrect inhaler techniques are common regardless of the device. So even those that seem very easy to use from your perspective, they come with certain errors that might be committed by the patient. So wherever possible, we should check the technique at every opportunity. If any errors are identified, we need to correct, retrain the patients, and recheck the technique again. And this should always be considered before you make any medication adjustments. Okay, so in terms of the devices, we can be mainly classified into these few classes. So the two most common ones are probably the MDIs and the DPIs, which are the dry powder inhalers. The main difference between these two is that the MDIs often require coordination between activating the device and the patient's inhalation, whereas for DPIs, such coordination is not needed, but they do require the patient to be able to inhale forcefully and deeply. Even within each of these classes, there are some differences. So DPIs, for instance, they come in the form of pre-inhalers, in terms of tubular and also available as acute-inhalers. So do consider the within-class differences between the devices as well. Next slide. So some possible scenarios that you might come across when you see your patients. For those who have a lack of inspiratory strength, do consider using an MDI, with or without a spacer, okay, instead of a DPI. On the other hand, if they have coordination issues, okay, they do have sufficient inspiratory strength, then you should consider a DPI. In both scenarios, actually having a spacer would solve the problem. It's just that some patients may not be so keen on getting a spacer because it's quite bulky and difficult to bring around with them. Okay, but where possible, we should recommend the use of a spacer. Okay, the third scenario is that some patients, due to dexterity or strength issues, they may have difficulty pressing down on some of the devices, such as the MDIs. So in this case, as before, if they have sufficient inspiratory strength, you should consider the dry powder inhalers. We should avoid the soft mist inhaler as well, as they do require some strength to load the device as well as to turn the knob. And finally, there are some patients who just have difficulty in adhering to multiple dosings a day. So in this case, you can choose one of the longer acting agents that requires only once a day dosing. Next slide. So when switching patient's treatment, for example, stepping up their treatment for poorly controlled asthma, you should also consider using devices that are familiar to the patient and that they are competent at. So just to state two examples, for instance, if a patient is already on the budesonide tubular and you wish to step up the treatment by adding a LABA, you should use the budesonide formoterol tubular so that the patient does not have to relearn a new technique. So similarly, if the patient is on fluticasone, which is in the form of a PMDI, you can switch it to salmeterol and fluticasone so that they maintain the same device. Next slide. So just to quickly highlight some of the common errors. So as mentioned earlier, the most common error that you might see with the dry powder inhaler is not inhaling sufficiently forceful. Okay, and other possible errors would be tipping the device after they have loaded the dose. Okay, for the PMDIs, the main problem is the lack of coordination. And also, sometimes the patients tend to tilt the head downwards too much. So this might actually affect the flow of the aerosol into their lungs. So I'll not cover this in detail. In the next slide, you can see some of the, any other additional areas to note. Okay, so for some of these, especially the DPIs and acute-inhaler, there is a lever. So you should instruct the patients not to play with them too much because this will actually waste the doses, even though the devices are smart enough to not allow for overdose. Okay, for those with dose counters, do ensure that the patient checks them regularly and not run out of medications. If in terms of the details for storage and in-use shelf life, there are also differences as well. So for instance, the Relva Ellipta is actually can be used for 1 month. Okay, so all of these details are actually in the product inserts. And as mentioned before, do consider the use of a spacer as it overcomes most of these problems. Okay, next slide. So I will not touch on every single device in detail, but we do have inhaler device technique videos available on the ACE website as well. So do visit the website or scan the QR code to take a look at all of these videos, which you can use to show your patient as well. Okay, next slide. So to summarize, the choice of inhalers should always check for the patient's preference and the ability to use the devices correctly. Okay, regularly review the use of the inhalers with the patient and recorrect when necessary. Consider other things such as inspiratory strength, the ability to coordinate, whether the patients can handle the device, as well as cost to the patient. And you should apply the same principles when you step up or step down the treatment. And lastly, I'd just like to emphasize once again that different ICS, even though they might have similar efficacy and safety at the same dose ranges, these recommendations of the dose ranges are not considered to be equipotent. So any change from one type of ICS to another, or when stepping up or stepping down treatment, should warrant a closer monitoring with the patient. Yeah, next slide. Yep. So now I think what would be more useful is to discuss some cases with you. So I would just hand over the time to my colleague Joy, who will touch on some real life scenarios they might come across.
Hello, everyone. Okay, thank you, Kheng. So I'll go through one case scenario with you in view of time. So maybe we start with a poll first. Have you ever seen a patient with asthma on SABA-only treatment? Options are yes, no, or not applicable. And then the second question is, how frequent do you counsel patients with asthma on the importance of adhering to preventive treatment? Rarely, which is about 25% of the time, or sometimes, often, all the time, or not applicable. Let's wait a few seconds to see the results. Okay. Oh, so from the result, it shows that it's quite a fair bit of has seen patients with asthma on SABA-only treatment. So I guess that's why we are here today. And let's see. And it's heartening to know that all of us do a great job in our work. So we counsel patients, most of us counsel patients with asthma on the importance of ICS compliance all the time. Okay. Next, I want to walk you through a case that commonly seen in community pharmacy. So Madam A, 42 years old, present to fill a prescription for Ventolin inhaler as below. So you understand from her, she's not using any other inhaler or medications apart from Ventolin inhaler. So she shared with you she has been experiencing SOB occasionally in the past few weeks. After she caught the flu and Ventolin works well for her. She further shared with you that she doesn't feel that she has asthma, despite the doctor telling her that she has. Next slide, please. So for this case, as you can see, how will you approach these situations? A, dispense 2 Ventolin inhaler and urge her to go back to see a doctor if she uses Ventolin often, as in more than twice a week. Or dispense 1 Ventolin inhaler, follow up the next day to assess how she's doing and urge her to go to follow up with the doctor. C, before deciding whether to dispense, ask more about her condition and medication use. Call her doctor to confirm if needed or if possible, particularly on any ICS use. D, reject her request and urge her to consult her doctor immediately, or none of the above. Okay, so yes, before deciding whether to dispense the Ventolin inhaler to her, it's important to find more about from her. So we see that there's a need to strengthen her knowledge of asthma. She mentioned to you she does not feel that she has asthma, so you need to explain to her no symptoms doesn't mean that she does not have asthma, especially if her symptoms is minor. And try to find more if there are any other symptoms except from the SOB that she shared with you could, before and after catching the flu. For example, does she experience cough, especially cough at night? And also try to ask her, find more from her. If there are any other inhalers given prescribed to her before or after the flu, and then take the opportunity to explain to her there are difference between these 2 inhalers. SABA is for short-term relief, but ICS is to act on the disease process to prevent the attack. And last but not least, it's important to highlight to her the risk of SABA overuse or over-reliance, because we understand that this is associated with poor asthma outcome. So if you finish 1 SABA inhaler in 2 months' time, it's a risk factor for more severe outcome. So in this case, patients need to be on preventive. So try to discuss with the doctor if needed and if possible. So I think in view of time constraint, I will drop the second case. And now, okay, so this is the last slide on non-pharmacological advice. So for all patients with asthma, remember to advise them to take annual flu vaccines, pneumococcal vaccine if necessary, pneumococcal vaccines, and COVID-19 vaccine if the asthma is well controlled and with no recent exacerbations. Encourage healthy diet and moderate exercise. Provide appropriate precautions about exercise-induced asthma. Avoid indoor and outdoor allergens. Limit exposure to the trigger if this cannot be completely avoided. Last but not least, encourage smoking cessations if applicable. So now we come to Q&A sessions.
Thank you very much, Joy, Kheng, Yong, as well as Sister Lathy for your insightful sharing. So before we move on to the Q&A proper, I would just like to share some additional patient education resources provided by ACE that you may wish to use if desired. So one of it is basically, for example, this fact sheet to debunk the common misconception about steroid inhaler usage. You can access the resources using the QR code. Next slide. And this is another example of a resource that you can use, a patient education flip chart, which you can use as a visual aid to educate patients on various aspects of asthma. Of note, a question that we receive at registration would be that few patients actually understand how prevention can be cheaper in the long run. So in fact, the picture at the bottom may be a useful picture that you can use to show patients that by appropriately using preventers upfront, it will actually help to reduce all the undesired outcomes down the road, which would be associated naturally with higher costs and undesired effects. Next slide. So now we come to the Q&A section proper. And I think looking at the Q&A part, I think some we have answered by the Zoom Q&A function, but perhaps there are some additional questions. For example, with regards to the Ventolin reliever, would Sister Lathy be able to help to answer this question about how we can tell and teach the patient when to replace the Ventolin inhaler when it's finished, because it does not come with a dose counter?
Okay, very good question. So for Ventolin inhaler, there is no discount, the counters, right? So what we usually advise our patient is to write the expiry date on that canister. So when we write the expiry date, then when the patient goes and visits the doctor, she knows when the Ventolin inhaler is going to expire, so he has to replace it. Another way of is removing it from the canister and estimating how much is left in the canister. That's the only way we can, because for preventer inhaler, we can calculate and say it should finish within 1 month. One canister lasts a month, whereas Ventolin depends on the usage of relievers. So these are the way which we can do. Write the expiry date, patient carries it, and remember when is the expiry date, and estimation. Thanks. Hope it is helpful.
Thank you, Sister Lathy. Sorry, Sister Lathy. There's also another question about in the current COVID pandemic situation, how do we actually check the patient's inhaler technique? Would you have some advice on that?
Yeah. So we do check techniques because we are wearing full PPE at our clinic section, and if the patient is a new case, and especially if meter dose inhaler is to be really thought and seen whether they are using it or not, so we will ask them to do it in front of us at our clinic section, because we are wearing PPE.
Okay, thank you very much. If there are more questions, please send it through the Zoom Q&A. We'll try to answer as much as possible. So in general, asthma is a chronic airway condition. So asthma is a chronic condition. So the patient, technically, we would not tell them that they will outgrow it down the road, but perhaps with different phases in life, the amount of medication required to achieve a good control of the asthma may vary, and it may be able to come down, but it may also go up. But in general, inhaled preventer treatment with daily ICS is the way to go, even for very mild asthma at step 1, step 2, even if they're minor or infrequent symptoms. There was a question also about doing peak flow monitoring. In general, we don't do it routinely in the clinic, but it is useful for us sometimes to be able to quickly assess if the patient's peak flow in clinic on that day it's lower than the baseline, but this is provided you actually know what the patient's baseline reading is. Yeah. And in general, in low resource country where spirometry may not be so easily available, peak flow will also be useful. And if there's not good access to spirometry, we can actually do peak flow diary to help to confirm the diagnosis of asthma. Okay, there was a question about a young boy, 4 years old, who was not formally diagnosed to have asthma, but having quite frequent wheezing sound when having flu. And they were advised to give salbutamol inhaler quite often by the GP, and wondering whether or not is it good to give salbutamol so often. I think short of being able to comment exactly on the entire clinical context, sometimes during viral infections, we can get viral bronchitis, and that can cause bronchospasm. And the purpose of salbutamol is to bronchodilate and to relieve the airway obstruction. So if the patient is symptomatic, there would be a role to use salbutamol inhaler, but generally, as long as you keep within what is the maximum recommended for that age, it is perhaps all right. But if you're not sure if the amount of usage is exceeding the age-related maximum daily dose, then it will be good to go back to confirm with your GP. Sister Lathy, there was a question on any simple bedside technique to assess compliance with ICS. Do you think you would be able to comment on that?
Okay, assessing compliance at bedside. So at bedside, usually when we go and see our patient, we want to ask patient to identify the inhalers, because most of our patient will not be able to tell us the name of medicine. So if we show them which is the inhaler, then they will let us tell us which is the inhaler. Then the way we ask them the questions, we can find out whether he is taking the medication or not. So you just ask them, so which is the medicine out of the blue and the orange color, which is the one which you use it on a regular basis? Just questioning the patient tactfully, we will know whether he is compliant or not compliant. If we are not able to check on our back and our refillings.
Thank you, Sister Lathy. There was a question from the audience as well about Symbicort Repihaler, PIL, whereby it's advised to give 2 puffs whenever administering a single dose. So if the question is with regards to use of rescue, then the question was, can it be given as a single puff instead, but to double the strength for possible cost saving or easier use for the patient? So I presume in order to do that, we would actually have to end up changing the patient to a different inhaler device. That means it could still be Symbicort Repihaler, but at a stronger dose in order to give it as a single puff. So that would actually result in the patient being prescribed an additional inhaler. Yeah, so it may not actually result in cost saving in the end as well. So, and may be confusing if the patient is beyond the yellow zone. I hope that answered the question. I think another question that I would like to answer is also, there was a comment saying that cost is one of the hardest things to mitigate when shifting mindset away from Ventolin due to the higher cost of Symbicort and Seretide. I think that is true, but it is an area that can be worked on with the patient, like what we mentioned. There are patient education resources, like I showed earlier, whereby by showing that the Ventolin doesn't actually modify the underlying airway inflammation, and that regular preventer usage with ICS actually goes a long way in terms of preventing hospital admissions, GP visits, and OCS use. There are a lot of cost savings indirectly in this sense, rather than looking at just a short-term cost of how much a Ventolin costs versus Symbicort and Seretide.
Maybe just to add on to this question, it also depends on the context. So if the patient is using a lot of SABA without any ICS, right? Actually, the cost of the ICS alone without the LABA component is not that much more expensive than using SABA. And if compared to, if they are using the SABA so much that they are having unscheduled healthcare visits, all those costs also add up as well. So it might be more cost effective to use at least a low dose ICS to control their asthma.
Thanks a lot, Kheng Yong. In the interest of time, as we have overrun, I think we'll just try to take one more question and we'll end the session. Okay, there was one question on what's the maximum dose of rescue puff Ventolin for children. So in general, if they are more than or equal to 12 years old, the maximum dose will be similar to adult, which is 800 micrograms per day, which is equivalent to your usual of 2 puffs QDS, 8 puffs per day. But if the children is very young, a ballpark that you can use is to calculate by the weight. That means 0.2 to 0.3 puffs per kg to see how many puffs that comes up to as a rough idea. But in general, yeah, it will be, as long as they're 12 and above, it will be quite similar to adults. So with this, I think we will have to close the Q&A section. I really thank you for your invaluable time spent with us. Please take some time to help us fill in a feedback form so that we can see how we can improve future sections. And I really apologize for not being able to answer all the questions input over here. And we thank you very much and have a good rest of the afternoon.